Acute Respiratory Distress Syndrome, or ARDS, is a condition where there's inflammation throughout the lungs, leading to pulmonary edema. The main site of injury in ARDS is the alveolar capillary membrane. Now, any damage to the alveolar epithelium or the capillary endothelium increases the permeability of the alveolar capillary membrane, causing fluid to move into the alveoli. Oxygen and carbon dioxide have to travel across this fluid, so it acts as a barrier against normal gas exchange. The fluid also dilutes out the surfactant molecules coating the alveoli, and as a result, the alveoli are less able to remain open and compliant, so they become stiff. If the injury continues, the alveoli eventually collapse. Now, the pulmonary edema from ARDS causes the same problems as pulmonary edema from congestive heart failure. But because the triggering events are different, the term non-cardiogenic pulmonary edema is often used for ARDS. Now, ARDS is not a primary lung disease. Rather, it arises as a complication of a systemic injury that causes widespread inflammation, which results in damage to the alveolar capillary membranes within the lung. The most common underlying systemic cause of ARDS is sepsis, which causes systemic inflammation in response to an infection. But other injuries include trauma, severe burns, near drowning, disseminated intravascular coagulation, or DIC, acute pancreatitis, massive blood transfusions, aspiration of gastric contents, and toxic smoke inhalation. The list basically includes any serious trauma that directly or indirectly affects the entire body. So, as you would guess, individuals with ARDS are very sick and have severe shortness of breath, tachypnea, hypoxemia, and diffuse crackles on auscultation of the chest. At that point, it's important to look for an underlying cause, like pneumonia, urinary tract infection, or an infected intravenous line, all of which might result in sepsis. Other clues might include epigastric abdominal pain radiating to the back, along with a history of alcohol binge or gallstones, which indicate acute pancreatitis. It's equally important to make sure that the signs of pulmonary edema are not due to heart failure. An elevated jugular venous pressure, an S3 heart sound, orthopnea, and paroxysmal nocturnal dyspnea all clue towards heart failure, and these findings are not present in ARDS. ARDS is clinically diagnosed by fulfilling the following criteria. The symptoms developed within 1 week of the suspected injury. Chest X-ray shows diffuse bilateral opacities. The symptoms are not fully explained by congestive heart failure. And the ratio of the partial pressure of oxygen in the arteries, or PaO2, to the fraction of inspired oxygen, or FiO2, is less than 300 millimeters of mercury. The first two criteria are usually straightforward. For criteria 3, there are some ways to help objectively determine whether congestive heart failure is contributing to the pulmonary edema. First, you can measure the serum brain natriuretic peptide, or BNP levels, which are elevated in congestive heart failure. Second, you can do an echocardiogram, which would show an ejection fraction below 55% in systolic heart failure, and abnormal relaxation of the myocardium in diastolic heart failure. Third, you can insert a Swan-Ganz catheter and measure the pulmonary capillary wedge, or PCWP, which is a reflection of the pulmonary venous or the left arterial pressure. The PCWP is increased in heart failure, typically over 18 millimeters of mercury. The PCWP increases because blood backs up into the atria and subsequently into the pulmonary veins, increasing the hydrostatic pressure in those veins. In ARDS, BNP levels, the ejection fraction and myocardial relaxation, and PCWP are all normal. Now, measurement of the PCWP is the most accurate in differentiating ARDS from heart failure, but it's not routinely done because it's invasive. For criteria 4, an arterial blood gas, or ABG, is needed to calculate the PaO2 and the FiO2 ratio. The PaO2 is measured in millimeters of mercury, while the FiO2 is measured as a decimal between 0.21, which is the FiO of the atmospheric air, and 1, which is the maximum FiO2 you can artificially give an individual. In ARDS, the edema of the alveoli prevents adequate ventilation, and some blood ends up in the left atrium without being oxygenated. As a result, giving extra FiO2 doesn't fully correct the hypoxemia, because blood passing by edematous alveoli simply aren't participating in gas exchange. This means that the PaO2 doesn't rise in accordance with FiO2, which decreases the PaO2 to FiO2 ratio. And the more alveoli are affected, the lower the ratio. For example, let's compare a healthy individual with an individual with ARDS. A healthy individual breathing room air, which has an FiO2 of 0.21, would have a PaO2 of 100 millimeters of mercury. So a partial pressure oxygen, or PaO2 of 100, divided by an FiO2 of 0.21 is 476. Now, an individual with ARDS may require an FiO2 of 0.5 to achieve a PaO2 of 100. So that would be 100 divided by 0.5, or 200. And if the individual with ARDS needed a higher FiO2, say 1, then their ratio would be only 100. Therefore, the PaO2 to FiO2 ratio can help determine the severity of ARDS, which corresponds to mortality rates. A ratio between 200 and 300 is considered mild, 100 to 200 is moderate, and less than 100 is severe ARDS. When it comes to the treatment of ARDS, it's crucial to diagnose and treat the underlying cause. For example, giving antibiotics to an individual with sepsis. Now, to address the ARDS directly, the FiO2 is adjusted to try to maintain an oxygen saturation above 88%, and the individual is usually intubated and mechanically ventilated. But see, in ARDS, the alveoli are quite fragile, and so the positive pressure that comes from mechanical ventilation can actually over-distend the alveoli, worsening the ARDS. That's where lung protective ventilation comes into play. This strategy includes giving the individual a low tidal volume, which doesn't over-distend the fragile alveoli, with the maximum tidal volume being 6 milliliters per kilogram. Low tidal volumes contribute to a lower minute ventilation, the total volume ventilated in a minute. And that means that the individual is expelling less carbon dioxide. But that's okay. That's called permissive hypercapnia, meaning that there's some respiratory acidosis that will occur as a part of the trade-off of protecting the alveoli from injury due to high tidal volumes. Additionally, because many of the alveoli are compressed or narrowly collapsed, it's important to use high positive end expiratory pressure, or PEEP. Typically, when a healthy individual breathes out, their alveoli collapse at the end of expiration and then easily pop open again with inspiration. But in ARDS, because there's a lot of fluid and the surfactant is diluted, the alveoli might collapse and then not open again. So we give ARDS individuals a bit of positive pressure right at the end of expiration, so that their alveoli are always open and don't collapse. This also helps reopen some alveoli that have already collapsed, increasing the available surface area for gas exchange. As an added benefit, recruiting more alveoli and preventing them from collapsing also prevents over-distension, because the alveoli share the tidal volume, decreasing the volume that each individual alveoli ends up having. So think, peeping is sharing. Now, a few additional things that can be done in ARDS to decrease the pulmonary edema include restricting intravenous fluids or giving diuretics, assuming that this is safe to do. Finally, when you think of mechanical ventilation, you picture an intubated individual lying supine. Well, flip your thinking and that individual. Prone position ventilation has been shown to improve oxygenation and mortality rates in severe ARDS. One theory on why this might work is that the heart and abdominal organs don't compress the lungs as much in the prone position, allowing the lungs more room to expand. Finally, it's worth mentioning that corticosteroids have no role in the treatment of ARDS. Alright, now for a quick recap. ARDS is diffuse lung inflammation and pulmonary edema due to a systemic illness like sepsis. The diagnosis of ARDS requires symptoms developing within 1 week, bilateral diffuse infiltrate on a chest x-ray, symptoms that can't be explained by congestive heart failure, and a ratio of PaO2 to FiO2 that is less than 300. Management includes identifying and treating the underlying cause, oxygenation, and mechanical ventilation. To prevent ventilation-induced lung injury, a combination of low tidal volumes below 6 milliliters per kilogram and high PEEP are provided. Finally, prone position ventilation has shown to improve the outcomes in individuals with severe ARDS.